All right, hi everyone. Good afternoon and welcome to today's webinar on addressing social needs through value-based care. My name is Melissa Quick and I am a co-chair of Aligning for Health. Today we are excited to speak with you about how 3 innovative organizations are working to improve health outcomes by leveraging value-based care to address both health and social needs. But before we start, I wanted to share a little bit about Aligning for Health. Aligning for Health is an advocacy organization focused on addressing the barriers and challenges that limit our ability to improve health outcomes and well-being for all. We believe that healthcare is only one piece of this equation, and that social determinants factor into our overall health and well-being. Lack of adequate housing and nutrition, socioeconomic status, and race all contribute to our health. Unfortunately, as we have all seen, the current COVID-19 pandemic has provided a real-time example of how such social factors can lead to disparate health outcomes and disproportionately impact certain communities. As we'll discuss in more depth, our current health and social service infrastructure and systems largely function independently of one another, making data sharing, financing, and coordination of care and services difficult to achieve. These challenges serve to further strain the social safety net and place additional burden on the people that it serves. As a coalition, we are focused on developing and promoting actionable policies to address such challenges and to create opportunities for states and local governments, healthcare organizations, and non-healthcare organizations to work together to develop cross-sector coordinated solutions to address health and social needs. So for today's webinar, we are excited to highlight the work of several organizations that are working to bridge some of the current barriers to leveraging value-based care. To date, our healthcare system has largely focused on providing medical services. Now, with the growing use of value-based care, payers and providers are increasingly taking a more expansive view of what it takes to improve health and are taking steps to better identify their patients' health and social needs and connect them with the resources and supports they need. Value-based care also helps organizations to take advantage of more flexibility to fund supports and services that occur outside of the doctor's office and leads many to build stronger relationships with community-based organizations and other local service providers. Our presentation today will highlight 3 Aligning for Health member organizations that are leaders in this space to talk about their work, the challenges of implementing and scaling such arrangements, and what comes next. So first, we'll hear from Centene, a health plan serving more than 23 million people across the country and in all 50 states. UPMC Health Plan, a health plan owned by the University of Pittsburgh Medical Center, which recently created the UPMC Center for Social Impact, which you'll hear more about today. And finally, Signify Health, a leading provider of technology-enabled in-home care and complex care management services. We aim to leave time after the presentation for questions and discussion, so please type any questions that you have for the panelists into the Q&A box, and we'll go through as many as we have time for. So with that, we'll turn it over to Laura. Laura Sankey is the Vice President for Product Strategy and Social Determinants of Health for Centene, where she collaborates with health plans, CBOs, and cross-sector partners to identify and address the social needs of Centene's Medicare, Medicaid, and Marketplace members. Laura also serves as co-founder and CEO of Social Health Bridge, a subsidiary of Centene, where she works to standardize process and measurement and create sustainable revenue streams for CBOs by improving health outcomes for health entities. Laura?
Thanks, Melissa. So appreciate the time today to talk about social determinants of health and value-based care. You want to move on to the next slide? So in 2018, I was asked to kind of jump into Centene's SDOH realm and really understand what had been happening and where we needed to go. I think as we jumped into that work, we quickly identified that Centene was focused on social determinants of health long before the buzzword came to be. Just by the fact of our bread and butter was really our Medicaid population, and that, as we know, many of those individuals within that Medicaid population are experiencing social determinants of health needs, whether or not we called it a buzzword of social determinants of health or not. And so, as I quickly jumped in and started to assess what our health plans were doing across the country, we quickly identified, yes, we were already doing some screening for social determinants of health through our health risk assessments. We were already addressing some of those needs through our care management model. We were definitely making referrals to community-based organizations, although, as we know, there's more and more of these CBO technology platforms that have come to be since that time. So maybe we were making referrals, but we didn't always necessarily know what was happening by way of those referrals until we connected with our member again. And then certainly, we were spending time working on national programs, Start Smart for Your Baby, our Member Connections Community Health Worker Program, trying to think of ways that we could really extend the reach that our care management teams had. We were certainly looking at population-specific offerings that addressed SDOH, really drilling down into diabetic members and how we needed to serve them, or how to address discrepancies in care for those pregnant women. And definitely started to kind of think through innovative pilot programs. We were definitely doing some grants within the communities in which we serve, but we weren't really necessarily measuring appropriately. So all of that is to say we were doing a lot of work, but we didn't have a whole lot of structure in place. So we started to really focus there and start to make sure that our health plans not only understood SDOH and the work that they had been doing, but really thinking about where this was headed. You quickly saw that it was all about measurement, trying to get to some standardization, trying to understand how to do some of these partnerships to extend the reach behind the work that was happening at the managed care company, and really trying to kind of extend and supplement that. And so in doing so, I think there were some key learnings that we identified. So if you'll go on to the next slide, please. I think what we found was, even though we were doing some of this work, some of the infrastructure that we were building was certainly helpful. But I think we quickly found that as we were engaging with some of these community-based organizations, that it was just a long tail. I mean, it took a long time to have some of these discussions to really coalesce around how we were engaging with one another, what the end goal was. We would certainly coalesce around the mission, around the vision, about what we wanted to achieve. But certainly we saw just some real gaps in the process, meaning that there were certainly cultural differences, there were language differences. We would literally be talking about value-based payment and HIPAA compliance and data sharing agreements and quality metrics and HEDIS measures. And we were talking with a food bank who was saying, I don't know what you're talking about. I have USDA regulations and I'm dealing with commodities, and we're scratching our head saying, I don't know what you're talking about. And so those language barriers really just struggled to get us to some effective collaboration. I would say the other barrier that we came upon was just the extreme fragmentation. If we wanted to work with somebody in the food space, certainly we had food banks and food pantries that we could go to. But if we needed to work through housing solutions, there were a variety of other sectors and partners in that silo. If we were working on transportation, there's another silo, and it was all very fragmented. And so we got to thinking about the fact that it's so difficult to get to any kind of a scale because it's just so fragmented and it's all over the place. And so how are we ever going to get to contracting on value? And then the third piece of it was just really a lack of standardization. Think about as SDOH became the buzzword. Certainly MCOs woke up to this, PCPs and other provider systems woke up to the fact that yes, social needs is really driving a lot of the cost, but how are we going to understand who's responsible for addressing these needs, and how are we going to go about it in a way that meets the needs of the member first and foremost, but then also meets the needs of those community-based organizations that we're dealing with. And the only way that we could get to that is through some standardization. Centene might be asking a food pantry to do some additional screening and send it back on a certain form. A competitor might be asking for some similar information, but on a different form. And so you can imagine the lack of standardization and real measurements really made it difficult to get to any kind of a value-based arrangement. And so with all of that in mind, if you'll go on to the next slide, please. We took a look at that and said, gosh, what's really missing within the marketplace here is really this convener, somebody that's kind of sitting in the middle, connecting and being almost like the interpreter of this. And so we really thought about this hard and did a little bit of digging and said, gosh, this could be its own market. And so we started touring some affordable housing communities, looking at the SASH model, which really kind of delved into resident service coordination, the use of community health workers to do some of that social determinants of health work. And we were thinking about it in terms of if you really had somebody sitting in the middle, connecting health entities to some of these CBOs, how could you do that? How could you get to a scalable, sustainable, and value-based solution? And it really came to light to say, gosh, if you did have something sitting in the middle that was able to be that interpreter, you could aggregate that scale, you could reduce that administrative burden, you'd get to some standardization. And so we actually built a company around it. Social Health Bridge is the name of the organization, and as Melissa said, it's a wholly owned subsidiary of Centene, but it's meant to be an external solution. And so what we thought about was, if you bring this to bear, what you get is the ability to get to scale. That you, for healthcare entities, basically you're getting one single easy way to address the needs that you have to address SDOH for your membership. You get the ability to track and improve outcomes by partnering with a variety of community-based organizations. And you have a partner that's willing to go at risk for those types of engagements. On the CBO side, certainly what you get is by starting to get to that standardization and to that value-based contracting, you start to get the revenue that you so desperately need on the CBO side. We know that CBOs are dependent upon grant funding and donations, but we have to move away and get to something that's more sustainable. And so by way of partnering with community-based organizations and healthcare entities, those CBOs, through this standardized format, start to get to value-based arrangements and start to get a sustainable revenue stream. It's one single easy way to engage with many, and it certainly should serve as a differentiator when seeking other grant funding. We don't think that grant funding or those donations are going to go away. What we would say is, by way of having this measurement capability and by way of having these arrangements, you start to differentiate yourself if you're a CBO, to be able to talk about things in terms of not just pounds of food that you're putting into a community, but pounds of food that you're putting into a community, and the fact that you've also improved the diabetes score for these 100 members, and you're literally helping improve the health of that community. And so Social Health Bridge is literally a startup, so a startup within Centene. If you'll go on to the next slide. Where we're starting is within affordable housing. As I said, when we were talking about this idea, we started to just really tour some affordable housing communities in the South and Mid-Atlantic states, trying to understand what that model looked like. We knew that within the SASH model that came out of Vermont, that there were some good results that came out of it, but that we thought we could maybe improve upon it. But that we knew that resident service coordination that's funded through HUD, really had some good results, but maybe we could layer on additional tasks for them that were more health related. And so this is the idea, is that we've got community health workers that are in affordable housing communities. And if we were just doing this for Centene, it'd be a pretty expensive solution, quite frankly. So in this diagram, what you see is, imagine a building where maybe you have 500 units, and maybe Centene only has members in 100 of those units. If I was paying for two community health workers actually, to serve my 100 members, that's an expensive model, and I don't know I'm going to get the ROI on that. But if I can capitalize on the services that those community health workers are doing, and I can sell that externally to other providers, other payers, that you start to get that aggregation, that you start to spread the cost of that intervention, meaning the community health workers, across all of those payers, so that everybody's kind of chipping in and it becomes a commodity, if you will, that we're really sharing that service, really improving the health of that community by deploying that community health worker model, but in a way that spreads that cost out. If you go on to the next slide. And so what are we doing? I mean, it really is about that community health worker model, and I'm really excited to hear what Ray has to say a little later on about his model, because I think what everybody's realizing is it doesn't have to be a clinical person that's doing some of this work. For social needs, it's really about understanding that member, about understanding the needs that they have, and being able to connect them to other services that they may not have a resource for. And so within this model, if you can imagine, we're working with things like a ED diversion or reduced inpatient admissions, looking at addressing quality outcomes. So anything that a health entity is interested in pursuing, whether that's a hospital system, an FQHC, or a payer, certainly those are commonalities and things that people are interested in. And so imagine this community health worker being able to go knock on the door when Mrs. Smith gets home from the hospital to understand, did she get her prescription refilled? Did she understand her discharge instructions? Does she have her follow-up appointment? And does she have transportation to that follow-up appointment? Those are meaningful engagements. And by way of having that face-to-face communication, and by way of having that engagement and that relationship already built, we expect that we're going to see some better results than if it was just our health plan calling the member, trying to connect with them and take care of those same tasks. So, you know, it truly is around a prevention focus. So thinking about how you can ensure that folks are getting their routine screenings, that they're getting their immunizations, that they're making those appointments with their primary care physician. It's really around targeted risk mitigation, and that, you know, we'll address the needs of that particular customer depending on what it is that they want. And it's about really meeting somebody where they are. And in this case, it's an affordable housing community, but the model is built to be picked up and put into a variety of site locations. And so that you know, that really is the idea as far as trying to get to some kind of a scale, to get to some kind of a standard measurement, that we're going to start with this startup company, obviously, working in these locations, adding in to see, do you get those same results? Does this model work? And is it an affordable solution, so that as you start to see those results, you're able to infuse that revenue back out to those CDOs that are really doing the work. Next slide. That's it for me. I appreciate the time today, and I'm looking forward to answering the questions that you might have at the end.
Great, thank you. And I see we already received 2 questions. We'll go through all the questions at the end for all the speakers, but if other folks have questions, please feel free to continue populating them in the Q&A box, and we will definitely get to as many as we have time for. All right, thanks, Laura. So our next speaker is Ray Prushnok. He is the Executive Director of the UPMC Center for Social Impact. His role requires him to focus on addressing the employment, housing, and human services needs of community members. He joined UPMC Health Plan in 2011, where he previously led UPMC's MLTSS and DSNP products. Ray?
All right, thank you, Melissa. Thank you, Laura. You know, I think to kick things off, I'll briefly, you know, introduce our UPMC Center for Social Impact and talk about our approach to our work. So go into the next slide. And the next slide, please. So we, as you know, I think you heard from Laura, and I think as many organizations experience that, you know, we've been doing a lot of things, you know, that sort of fall into social determinants, but didn't often categorize it that way. It was sometimes the right thing to do, sometimes, you know, a benefit a benefit, sometimes a supplemental benefit, and sometimes just activity that fell through clinical management. We realized, and, you know, in my experience being on the, you know, product side of the house at UPMC Health Plan, that oftentimes these are the things that, you know, become your 3rd, 4th, or 5th priority. And we felt it was important to really bring focus to our collective work around the social determinants of health late last year. So our charge is to help build the strategy for our social determinants work, document and report on the contributions that are happening across our organization, to coordinate that work, and to develop and incubate pilots that help us learn and ultimately evaluate and disseminate those results. So the next slide. We think about this from a, you know, variety of perspectives. So the on the upper left, you know, we've all seen, you know, various, you know, images to the same effect, where there are, you know, about 20% of the health outcomes are, you know, driven by what happens in a clinical setting. And we've all seen that, you know, 80% is occurring, you know, elsewhere, whether it's, you know, in behavioral health, or, you know, from social and economic factors, and then your physical environment. But, you know, I think one of the things that we're coming to realize, while we acknowledge this, about 80% of what we know happens in that clinical setting. We're still learning. And I think that we look at this from, you know, the perspective of a health plan, and how do we sort of use our strengths to, you know, develop programming and drive results. We look at this from really that member-focused side, which, you know, can also be community responsive. You know, we also look at how we can apply evidence-based interventions with, you know, really an eye towards quality. And, that's really important from, the standpoint of CBOs working with health plans, in thinking about, while the health plan may be, interested primarily in its members, how do you work together around, broader community approaches? And health plans are always going to think about this from the perspective of, there are limited, premium dollars that can go into these types of social programs. And how do we wrap around and braid our resources to be most effective and to really deliver those results? And that's where, starting early with measurement is incredibly important, and really approaching each, intervention with a business case and thinking through what your, model for return on investment would be. And I think also important here is scalability. What often becomes difficult, and what we've, come to learn, is that through our programming, something that may work in Allegheny County or here in Pittsburgh may not work on the other side of the state in Philadelphia or in some of the rural areas in Pennsylvania. So with scalability in mind, being conscious of, how will you sort of implement a program where there, may be multiple community-based organizations that you're working with. And something that's always really important to emphasize is data and privacy. So as you think about the types of consents you might need from a community-based organization standpoint, and understanding a health plan's perspective around things like HIPAA, but there are also, different tools that can be used. We've built a lot of our platforms and, data arrangements, looking at how we can, essentially close the triangle. On sort of one end, we have a Medicaid payer, in the state, and they may be, working with other human services organizations, but there's nothing sort of closing that triangle at the bottom. So how can we, develop agreements that enable us to do that and be able to ensure privacy, consent, and in some cases, there may be opportunities that don't require sharing individual level data, and how do you work with organizations. And one thing I would, just highly recommend, if you're a, health plan thinking about getting into this work, get to know your local leaders in human services at a county and county level especially, and work with your state around getting important data points and things in programs like SNAP and other, benefits that your members might be interacting with. On the top right of this slide, you'll see sort of how we fit into our organization. There are a lot of places where we can have an impact, whether it's, on how we are investing our dollars, or there are ways that we can, be an anchor investor into programming. We've been spending a lot of time in recent years looking at affordable housing and how we can use our portfolio to really spur investment. And, similarly, how we spend our money from a supplier diversity standpoint. And then from, a charitable contribution and sponsorship side, those activities all sort of happened in the background, but weren't always connected to really the right side of this image around what are our core product benefits, what are our supplemental benefits, who are the organizations that our care management team is working with, where are they making referrals, and how does this connect to our mission? So where all of these activities maybe happen on their own track, sometimes differently across products, we established our new department to really help to close some of those gaps and build stronger business cases. I did want to highlight, how community-based organizations can think about working with health plans, in terms of just continuing to build and update your business case, and also thinking about shared resources and thinking about how you can work with a plan around their members. Many community-based organizations are thinking more community-wide, but plans are often thinking, as Laura indicated, how do we bring a coalition of plans together if, we all have, a large number of members in a specific building or in a specific zip code, and then how do we, collaborate and focus that programming. So next slide, please. So now I wanted just to highlight some of the work that we're doing and how it fits into our overall value-based agenda. So, first, to highlight housing and some of the work we've been doing in this area. We have a community partner, Community Human Services here in Pittsburgh, that we've been working with for more than a decade to support our members who are experiencing homelessness. So in that example, we have built in a few different incentives along the way, including on the front end, how do we make sure we incentivize our partner to help identify housing quickly for our members. And I first must say that all of our work in this area really requires the braiding of funds between HUD and housing choice vouchers, along with the resources that we bring as a health organization, along with the resources that our community-based partner brings. But with that, we've been able to, through years of effective programming together, the city and county have supported us by giving us access to return vouchers that were unused, and we are able to then rapidly house one of our members. And our community partner is really adept at finding units that are affordable, helping our member get stabilized, get furnished, make sure they have all of their bills set up, and they can support our member along the way. And then our community team is able to support our members in making sure that they meet all of their health goals and working with them to ultimately live their best life in the community. And through that, we also have built in incentives. So in terms of longevity, bonuses for our community partners, so that as we see the savings from someone being stably housed, our community-based partner can help us do that. That's been a really exciting program that we've begun to expand over the course of the last year, and we are looking to expand into some new counties. Secondly, in the housing space, we've been looking at ways to invest. So health plans, and in particular, have regulatory reserve requirements. We have investments typically that are not being put to unique areas like developing affordable housing or investing in our community. So we've been exploring ways to do that, including some recent investments in an organization locally called Omacello in the Pittsburgh area. In terms of testing interventions, we've been looking at how a variety of programs can be proven out to show value to the healthcare system. So where some things are intuitive, like benefit access, so a typical dual eligible, she may live alone, she may be in her 70s, she may have an income of about $700 per month through Social Security. That member can greatly benefit from some specific state programs, like our state's property tax rent rebate program, and other programs that she may qualify for but not be enrolled in, like Medicare Part B premium assistance or the SNAP program and LIHEAP. So we're beginning to evaluate as we assist members in accessing those benefits with a community partner organization. Can we begin to see impacts on overall quality and healthcare spending and time? We're also engaged locally on evaluating a Meals on Wheels pilot to see if we can measure the impact on our Medicare members in particular in participating in a Meals on Wheels program that includes an in-person intervention that checks up on the person's daily needs. And then also looking at some of the benefits that are offered in our Medicare and Medicaid plans and figuring out where they translate. So where a benefit like a 14-day post-acute meals program, how can we better understand for a Medicare population if it's working for those members that are over age 85 or members that live alone or members with specific clinical profiles? How do we apply that learning and begin to offer benefits in a similar fashion across different lines of business and products? So all of these areas, again, to help better inform how we decide where to invest and where different programs like food and transportation can begin to help bend the healthcare cost curve and improve our dissemination across the areas we serve. I alluded to integrating human services data. This is incredibly important, has been very valuable to us. So we have a partnership locally with Allegheny County, which is home to Pittsburgh in Western Pennsylvania, where we've been able to exchange robust data on aging, children, youth, and families, intellectual disabilities, and other data with the County Human Services Department that we've been able to use to help develop targeted pilots and identify partners. Our best example is over the course of the last couple of years working around people with intellectual disabilities. There are a lot of things that don't show up on a claim, and health plans can become victims of their own data. So when you think about a member who might be served by a community-based waiver We may not know that from our data sources from the state, and we certainly wouldn't know that from a claims perspective. We also, may not know that a person, is living in a residential supported environment like a group home, and we also don't know that members, may be on a waiting list for services. So through systematic exchanges with local county governments, we've been able to, create monthly case conferences with the organization serving these members, where they can bring their problem areas and we can bring the gaps in care and other areas where we're looking to help improve our members' health. That's been an incredibly effective partnership for us. And we've also established in the same vein a relationship around an honest broker where we can each exchange data in a more fluid way and be able to create member matches, so we can align ourselves with nonprofits that may be serving the same people that we're seeking to help. Lastly, I wanted to highlight some of the work happening around government payers. I think first to acknowledge Medicare Advantage and some of the increased flexibility, but also our state Medicaid office is seeking to better align community-based organizations with our value-based contracts. So that's been an increasing area of focus for us here in Pennsylvania. And we're looking at ways, again, in this same vein, to see what works for who and when, and how can we, begin to build stronger evidence like we've done in our support around members with homelessness, and apply that same kind of thinking to, how do we develop food programming, transportation, and other programming to support our members. So I'll stop there, and we'll be able to answer any questions at the end of our presentations. Thank you.
Great, thanks so much, Ray. All right, so last, we are excited to hear from Dr. Jamo Rubin, who is a strategic advisor at Signify Health. Before Signify, he was the founder and CEO of Tab Health, which is acquired by Signify, and is a company focused on resolving social determinants of health. Prior to Tab, he also founded and led 2 companies focused on pharmacy benefit management and healthcare contract management and payment verification. Before his entrepreneurial career, Dr. Rubin practiced as a cardiac anesthesiologist. With that, I will turn it over to Jamo.
Thank you, and appreciate everybody joining our conference today. And also thank you to Laura and Ray. They have developed some very interesting that are trying to solve this conundrum of social determinants of health within value-based care. And there's a theme within both of their stories, and that is outcomes. If these programs and these products and these services and things that you all are doing in the audience cannot generate a measurable outcome, then the idea that we're going to weave together public health, social service organizations, and healthcare providers in a value-based arrangement is never going to work. And these outcomes need to be measured from activity that's upstream from the healthcare system, and its impact as it flows down into the healthcare system where all the risk capital is, because that is essentially what value-based care represents. Well, what I want to share with you today is some of the places, and I've been thinking about this problem for 10 years, and I come from a real handicap in thinking about it, because I can tell you as a physician, the amount of training and awareness we had to social determinants of health was zero, which is also part of the problem. Well, here are some of the barriers and issues that I would encourage you all to think about as you work in your local communities and with your partners about finding solutions that generate the outcomes that you need to have sustainable models. The first one is there's a real risk to the healthcare community leading this effort. We don't really understand this, and I'm going to speak in generalities, but it's to make the point. Some of you, many of you might. But in general, healthcare does not understand this problem. As I've listened to initiatives around the country spawned by plans, providers, healthcare systems, their stance, although pointed in the right direction, often medicalizes the problem. This is not a medical problem. This is a social service problem that flows into the healthcare system, where we're standing at the exhaust pipe trying to say, how do I fix high blood pressure because this person isn't eating right? This is a high blood pressure problem. This is not a blood pressure problem. This is a Maslow's hierarchy problem, and the healthcare community has not been thinking about this for decades, and we're certainly not structured to act on it at scale. The second thing that's a problem for the healthcare system leading this conversation is that, inherent to value-based care, the healthcare system represents a flawed component of what is essentially an insurance model. Here's how car insurance is supposed to work. All the drivers pay their premiums. No one gets in a wreck. That's the beautiful insurance model for cars or for property and casualty or what have you. But in health, the way that we're structured is the only time a plan or a provider tends into a patient is after they've had the car wreck. They're already in the healthcare system. And the whole point about social determinants of health is, what can we do upstream in an area where I have little to no visibility and little to no data to prevent them from having a car wreck in the first place? So healthcare tends not to be inherently positioned in the right place to do the biggest impact moves on social determinants. Third, I'd like to point out that there's a lot of false hope in the surveys that everybody's talking about. And let me tell you why I believe that. And not that it can't get cured. But these surveys, the Prepare tool, there's any number of tools that are out there. But most of the people that are talking about the amazing data that's in these survey tools, I think are missing some important pieces. And that is, just because you have the data doesn't mean it's right. And here's what I mean. It's one thing to collect a history and physical in a clinical environment and ask questions like, do you have high blood pressure? Do you take medicines? But it's another thing to ask somebody about the dark secrets of their personal life. And think about that for a second. I'm in an emergency room. I'm scared. I hurt. I don't know who you are. And an untrained person sits down to ask me a social determinant survey screen. Okay, I don't know who you are. And my husband's in jail, and my son lost his job, and I just lost my home, and I live with my aunt. I don't think I'm going to share that with you because I don't know you. The second thing is that there is an element of trust that must exist for me to share information with you that may be shaming. I'm not going to tell you these things, one, because I don't know you, but two, I'm really embarrassed. And if you think I'm going to sit down in a little office inside an emergency room or a clinic and give you this first time not knowing who you are, it's probably not going to happen. The third thing is, as famous as the Prepare tool has become, and as effective as an instrument as it might be, have any of you read the Prepare tool? One of the first questions that this woman or this man is going to be asked is the following. And just put yourself in their situation for a second. I'm about to ask you these really personal questions. You don't know me. You're hurt and you're scared. And I say, has a migrant farm worker been your primary source of income in the last 6 months? That's one of the first questions in the Prepare tool. And it could be an enormously important question with big implications to the answer. But you know what my answer is? No. And as a matter of fact, any other question you ask me, I'm probably wondering why you're asking me this stuff. And is ice going to show up at the end of the hall when I walk out of here? So all this to say, in my exaggerated story, let's be really careful about the survey tools that we have that are driving our models and our decision-making, because just because we have the data doesn't mean it's right. It has to be acquired in an environment where trust is. And guess where that environment already exists? It exists out there. The social service organizations and these public health agencies probably already have long-lasting, deep relationships, and they know all these things about the family. The church knows, the food bank knows, but you know who doesn't know? Your Cerner system. So the idea that we're just going to magically merge these things together, I think we better be careful about imagining that. The next point that I want to make is that the healthcare data model is patient-centric. We've already talked about the fact that we're really looking for people that aren't patients yet, but the other piece is that when it comes to the world of social determinants, these are system problems. These are family system problems, not one person in an EMR with a medical record number, but a whole family, a dynamic, an interaction, not even with the family, but with the neighbor who answers the phone because the mom works and the husband's got early onset dementia and she can't leave her cell phone there. So how do we gather data at the family system level, and what systems do we use to do that? Well, that brings us to another massive problem. And Melissa, I'm wrapping up. Hold on, I'm catching up with time. But the other massive problem that often goes undiscussed, either because it's not recognized or it's too complicated, nobody knows what to do about it, is that when you're proposing the idea that social service entities, agencies, and healthcare organizations are going to collaborate in a longitudinal record to generate an outcome, because that's what you need is a longitudinal record, you are proposing the idea that a non-covered entity, food bank, church, agency, is going to be sharing information with a covered entity, health plan, provider. Now, everybody's scared to death of HIPAA. Got it. That's a privacy problem. That's really not what we're talking about here. That's just table stakes, because those non-covered entities out there like the food bank, they're not a party to HIPAA, but they have really sensitive information that everyone needs to know. Every state has privacy rules that apply to non-covered entities, and every state is different. Every community may decide whether or not it's the law. They don't know if they want to share this information. So there's a can I share it legally, state and federal? And should I share it as a community, as trading partners of information? Are we going to do this? All this is cloaked in an envelope of trust. And their shameless plug, there's only one platform in the country that is able to handle the assimilation of non-covered entity data and covered entity data and share it over time in a way that is safe and compliant and ethical, where members can decide if they want their information shared or not, and the food bank can see things that the plan may not be able to see, and so on and so forth. And that's Signify. But it was, we believed, a critical piece of the puzzle, because without solving this non-covered entity sharing with covered entity information problem, none of this is ever going to happen. Finally, I'll leave you with this thought. Social determinants of health aren't one thing. We're not solving transportation problems. We're not solving home problems. These social determinants of health happen in clusters. If I need transportation, it's probably because my car's broken. It's probably because I lost my job. And because I lost my job, I don't have money to pay rent, get my kids their school books, or buy my prescriptions. And so it requires a collaboration of multiple community and provider stakeholders to come together in a virtual team to solve these problems together. Like in healthcare, we have clinical comorbidities. In social determinants of health, we have social comorbidities. And framing the problem in that way gives you a higher chance of creating the outcomes that you need for your program to be successful. Okay, Melissa, I'll turn it back over to you, and hopefully I haven't used too much extra time.
No problem. Thank you, Jamo. So this was a question or a theme that I think spanned all of your presentations, and that is in the importance of, especially Jamo, you talked a lot about this, but the importance of kind of data collection and or having an informed set of data in order to inform any sort of information interventions that you're planning, or especially any value-based care arrangements. And then the flip side of that is measurement. So ensuring that to the extent that you are trying to better connect referrals or incorporate community health workers or whatever the intervention might be, then being able to collect data or perform data sharing amongst all the different participants and have robust data to use to be able to actually assess whether you've improved health outcomes or lower costs, whatever the goals of the intervention might be. So I'm wondering if each of you could talk a little bit more about that, about, the role that you see of data, both kind of data collection and screening and identifying at the outset, in order to prioritize or, identify which beneficiaries would benefit. And then, on the other side, in measurement and ensuring that there has been success.
I think very, very simply and quickly, I mean, I think the first place is being able to identify where you have mutual members or sort of mutual clients, and, that can be, accomplished in some cases, if you have the proper consents and agreements in place through a direct data exchange. We've, as I mentioned earlier, have leaned on relationships with government and human services organizations that may also have a relationship with Medicaid payers. But that's incredibly important for health plans as we begin to look at how do we build evidence that certain interventions are correlated with certain outcomes. And something we're very much interested in as an organization is, as you have community-based organizations that have an intervention, they have self-reported or other data to suggest it has a health impact, to be able to work with them to evaluate that impact and, begin to test that across other populations.
Yeah, and I would just add, we've taken a couple of different approaches. I mean, typically there's the standard approach to where we're engaging with a member, screening, doing some needs assessment, and making referrals to kind of get that data exchange going with the community-based organization via, CBO referral platforms. But there's also the flip side of that, which is how do you engage with CBOs to let them know, hey, I'm interested when my member shows up at your organization, if they self-identify as a Centene member, let them know I want to engage with them further and understand if they've got additional needs or if they, if I can help them in any other way. And so having those data sharing agreements with CBOs is just another way to think about it. So it's not always just about the referral. Sometimes truly about meeting people where they are, which is maybe they're showing up at Goodwill Industries and I need to have a data sharing agreement. When they show up, let me know who's showing up so I can reach them and help them further.
Yeah, I'll add, Signify's approach to this is we go into each community and set up a formal legal network, like for those of you in healthcare, a multi-plan network. But this is a formal network of social service and clinical providers that sign contracts to agree to share information according to HIPAA and any other state law. This is then partnered with a member consent. So every member can decide to share or not, to allow this network to share or not to share. Member consent driven legal infrastructure that grants permission for these folks to share. And this legal framework is then put inside of our longitudinal social record so that we can do things like what Laura says. She can generate a ticket from Centene to say, listen, Food Bank, if Johnny Jones shows up, would you let him know he needs a redetermination form, or I need to know what their mobile phone number is because they need an appointment and I'm happy to arrange transportation. So it generates a community-wide collaborative network with a longitudinal record. People are communicating in real time safely, and then they're able to measure outcomes because everyone is participating in the same information system that is known by the member and is approved by the member or turned off by the member.
Great, thanks. So to shift gears a little bit, so both Laura and Ray, you both talked about one of the interventions that you guys have kind of started out with as part of your programs has focused on housing and supportive housing, or making sure that there are housing supports available to your members through various different arrangements, and working with other payers, other providers, other federal programs that might be available. So I wanted to hope that you could give a couple moments on why you chose housing as a key kind of first step or first initiative, and some of the challenges that you faced in really trying to blend together healthcare services and housing services and working across different organizations to do so.
Sure. I think from our experience, members experiencing, homelessness tend to be using a lot of unplanned care and tend to be, a great opportunity and flagged for any number of clinical programs. But those clinical programs just simply don't work unless the person is stably housed and has, a place to go where then they can begin to, be able to think through the areas that we're looking for them to focus in on. So for us, it was just the practicality of working with some of, our higher cost members. I think this is one of those areas where, addressing an individual member's social needs isn't really looking at that sort of global, sort of social determinant that is, more of a society or policy level. And I think that's where we're also looking at how we can, as an anchor institution here in our service area, be able to help spur more investment and development of affordable housing generally that may not be sort of specific to members, but just the need really came from, these are our high need members, they're high cost to the health plan, there's great opportunities for quality improvement, and frankly, that's where you then begin to see the ROI that justifies more investment.
Yeah, I would agree. I mean, certainly, I think Jamo said Maslow's hierarchy of needs, right? You have to address where people are, and if somebody is literally not housed, that's a good place to start. So, when we're talking about on the Centene side, certainly addressing housing is important, and we've got other relationships outside of the work that we're doing over on Social Health Bridge, trying to connect people, identify, housing resources, be connected into the HMIS system, working with other organizations that do some of that work to ensure that people that have issues like poor credit history or a history of eviction, that we can work with other entities to say, like, can you overlook some of that if I can prove that somebody's a good tenant, and that we're able to kind of put ourselves out there to vouch for this person. So certainly housing is certainly the biggest need that some individuals have. I would say as COVID came, quickly, when we were scanning kind of the incoming and the outbound call campaigns that we were doing, we were obviously identifying that food insecurity was coming first and foremost for folks. And so quickly shifting into kind of relying on some of those partnerships that we had to be able to meet those needs and be able to assist people in getting connected to SNAP, as well as just trying to either do some service delivery, bringing food to people that couldn't get out, or wasn't safe for them to get out, or trying to address those needs in other ways by supporting organizations that put food into their communities.
Hey.
Nothing. Yeah.
I'm sorry. So another great question that came in the chat box, which I might expand upon a little bit, was thinking through, how do you balance the role of kind of health insurers or even providers, or versus the federal government or CBOs or otherwise in funding some of these services, right? So there has been a lot of discussion here, especially about, what are health plans or integrated, provider organizations funding, or some of the initiatives and work that you're doing, and the way in which you're working to partner with other organizations and or leverage or coordinate with, county agencies or other human services agencies to do some of this work. So just trying to think through, the different funding flows and how those all integrate together. And I think, Ray, you also mentioned blending and braiding, if you want to touch on that for a minute.
Yeah, so I mean, I think it's there's not enough, healthcare premium to patch all of the holes in our social safety net. So there, I think as we sort of look at where we can have maximum impact, it's, in part aligning the charitable work of our organization, and then all, and that's one piece, but then, where more of my focus is on how do we spend limited premium dollars on interventions that we can, begin to, prove out and bring evidence to bear. It is a tough area. There's not, necessarily going to be an ROI for a member who is well but experiencing homelessness, or a member who is well but has, a critical food need that will impact their health in the long run. And I think balancing those things is still a journey we're all going through as we begin to sort of look at how we make contributions for different reasons. Sometimes it's, from a, purely quality standpoint, or return on investment that we believe we can lower overall cost of care. Other times is critical to our mission and where we focus our community benefit dollars and charitable resources.
Jamo, did you want to jump in? I want to make sure you've got equal time.
No. Laura, please.
Okay.
Go ahead.
Okay. All right, sure. So yeah, I would just say, I think it's structured in a variety of ways. Some organizations will fund this coming out of like their charitable organization. So that's one way. Obviously, there's a lot of different parts and pieces that go into a managed care organization and the way that they are structured and kind of investing in this. So I think it's just really important for folks to be able to put in a good tracking mechanism. So it's not just always about grant funding that you're putting into a community, but time spent. How are your community health workers engaged in addressing SDOH needs? What other mechanisms are you putting in place to do some of that spending? Quite frankly, I think CMS could do a bit better of a job in thinking about providing some technical assistance to states to understand all of the levers that they have, thinking about ways to clarify around in lieu of services or value add services and how we can utilize some of those, by addressing those types of social services upstream, you're going to see that impact. But what is allowed and what's not allowed, I think sometimes states are a little cringy about some of that. So getting some technical assistance would be good. Definitely around kind of quality programs as well. So obviously it's very clear on Medicare when you're putting a quality program in place, that's an eligible expense. So is that the same for SDOH? I think there's just some uncertainty, and so we need to get a little clarity on that for states so that it's very clear. I had seen one last final thought. I had seen in the chat there was a question about premium slide, and I think this is another way to address that. If we get some good technical assistance from CMS, then people are very clear about what's in and what's out, and states might be able then to be able to think about, okay, well, how can I build SDOH into my capitation rate and kind of monitor that so that managed care organizations are then forced to really understand and be clear about what impact they're seeing, and we can address that premium slide head on.
Yeah, did you want anything?
Nothing to add.
All right. So recognizing we're at time, and I apologize, we did not get through all the many excellent questions. I just wanted to thank everybody again for joining. It was great to see such strong interest in learning about how organizations are working to address health and social needs. Let us know if you have any additional questions. You can email me. My email address is on the screen, and I can refer your questions to any of the panelists, and we'll hopefully get back to you. Additionally, we're excited to announce that we'll have our next webinar in our series will be on September 24th, where we'll hear from leaders from 3 health systems on how they are working to address social needs and improve community health. So thank you again for joining, and thanks especially to our panelists for their contributions. That was wonderful, and I guess everyone have a wonderful day. Thank you.